Good morning to everyone, and thank you for this very kind invitation. Today it's a really pleasure to have the opportunity to share my experience on this really challenging situation like is the instant restenosis, instant reocclusion. My disclosure. So, first of all, this year the concept of vessel preparation has become a crucial concept in all our endovascular treatment. In every our endovascular treatment is the first, the most important step after crossing the lesion. And the aim of the vessel preparation is to improve not only the immediate result, but also the long-term result by a number of actions based on the debulking of the plaque or the modification of the plaque using different devices, different balloons. All this in order to fight against stent and to following the concept to leave nothing behind. But when we treat a lesion like this with a really flow limiting dissection, plaque recoil, of course, the only possibility is to fix this situation placing a stent. Then the stent is mandatory in this case. But when we use a stent, we know that the Achilles heel of stent is the high risk of restenosis and reocclusion based on different biological process, above all in this specific area and the 𝗙-𝗙𝗋 level, and also based on the features of stent due to the radial force, the chronic outward force, and then the chronic inflammation, and then the restenosis. This meta-analysis showed that probably right now the best treatment for the instant restenosis is yet to come because we know the PTA alone is not effective. The drug-eluting balloon are effective, but just in the easiest situation, in a really short restenosis, than in 𝗔𝗂1 lesion. The problem is to treat the more complex situation than the 𝗔𝗂2 and then the 𝗔𝗂3 lesion. And probably in this situation, the debulking and the use of a drug-eluting balloon is the key of treatment. And again, this review meta-analysis confirmed that probably now the best treatment choice for the complex 𝗔𝗂2 and 𝗔𝗂3 lesion is the combination of the debulking and the drug-eluting balloon. Why the debulking is so important? The debulking is important to remove, of course, the neointimal hyperplasia, because the neointimal hyperplasia is different than the novo lesion. About 80% is an extracellular component, and then at the beginning of our treatment is mandatory to remove this to improve the drug delivery at the level of the artery wall, the smooth muscle cells. But also to remove the neointimal hyperplasia is really important to obtain an effective lumen gain, because if we apply the 𝗙𝗏-Poiseuille law, we know that there is a force-power relationship between the flow rate and the vessel radius. And then lumen loss about 50% is a reason of flow reduction more than 90%. And finally, in case of a more complex situation, then a complete occlusion, of course, the central part, the core of the occlusion, in many cases is a fragmentable material, acute, subacute, chronic thrombotic material with an high risk of distal embolization when we perform an angioplasty alone. So we have some different devices to perform the debulking. We can choose between some different devices. This meta-analysis show no differences in long-term result, and right now, in our experience, in our hospital, the first choice is to use the atherothrombectomy device, because in my opinion, this device has some advantages. The first one is that the rotating helix is able to produce an effective aspiration and then to reduce the risk of distal embolization of the fragmentable material. On the other hand, the rotating tip without blades produces an ablating vortex, and then this remove the hyperplasia, reducing the risk of stent fractures. These are the most recent publication about the use of Rotarex and drug eluting balloon with a good freedom from TLR at 1 year with a low rate of complication, and this is confirmed by our experience in a really complex lesion, because more than 90% are complete in-stent occlusion with a low rate of complication. So just to example, to understand in clinical practice the use of this device, this is a typical 𝗔𝗂 lesion, then a very long in-stent restenosis, no stent fracture. We treated this using a Rotarex 8 French, and after 2 passages of Rotarex and the use of drug eluting balloon, this is the final result with a residual, without a residual stenosis. And these are 2 more complex situations than a complete occlusion, 𝗔𝗂-free lesion, treated again using the atherothrombectomy device and with this final result. So, just to conclude, of course, the in-stent restenosis and above all the 𝗔𝗂2 and 𝗔𝗂-free lesion are a really challenging situation, and where probably the best treatment is not really clear. But the meta-analysis show that the treatment of choice right now is the combination of the debulking and the drug eluting balloon. In our experience, between some different devices to perform the debulking, we decided to use the Rotarex S, because this device has a really good long-term result with a low rate of complication. Thank you a lot for your time.